we have the Cancer Genome Atlas, and Yelena, can you tell us a little bit more about what that's about and how do we apply that?
Sure. So the Cancer Genome Atlas is an effort through the NCI to develop a roadmap, an atlas of different solid tumors, and there's an effort to do this in esophageal and gastric cancer, which the gastric cancer paper was published first, and recently we published the joint esophageal adenocarcinoma squamous cell, but also incorporating the gastric cancer data into it. And so the first iteration of this analysis demonstrated that within gastric cancer, gastric adenocarcinoma, there are 4 different molecular subtypes. And these are pristine, relatively early stage tumors that have not been exposed to chemotherapy or radiation, and really are not exactly translatable to the metastatic patients that you see in your clinic. So these are earlier stage tumors, and what we saw that among the 4 different subtypes, MSI patients, microsatellite unstable, and EBV, Epstein-Barr related tumors were the most PD-L1 positive and likely susceptible to immune checkpoint inhibitors. In that cohort of patients, however, the incidence of those tumors are likely overestimated, as there continue to be relatively favorable prognosis in early stage cancers. And so in that sense, that there's that data I'll put in quotation marks, because for your metastatic patient, it may not be as commonly seen. The most common tumors that we see in U.S. and going back in the West, going back to Ian's comment, that it is very complicated. It's not just about the type of surgery you do or the tumor location. It's also about the molecular characteristics of the tumor. And so in U.S. we tend to have more aneuploid or chromosomally unstable tumors. They're p53 mutant, they're aggressive. And I've had patients who are undergoing quote unquote screening for endoscopies and just had a normal endoscopy, and a year later they already have a T3N1 tumor. And it's because within 6 to 8 months, the tumor grew quickly, and generally those tumors are associated with chemotherapy resistance and aggressive tumor biology. In the H. pylori, or sort of the endemic type of gastric cancer, generally those are distal tumors that are less, aneuploid driven and could be potentially less complicated to target. And then, to Manisha's point, the signet ring cell or the diffuse gastric cancer is a completely different entity. It's very difficult to pick up sometimes on endoscopies. They tend to grow on top of things in sort of, into forming a mass. So this is Linitis plastica approach. And genomically, they're very quiet, at least on the DNA level. So it's something, there may be claudin inhibitors as one mechanism of treatment, targeting ROA pathway, although that's a big question mark. They're a big challenge. Within esophagus cancer, one thing we know is that squamous cell tumors are a completely different entity, and actually phenotypically and genomically are more similar to the head and neck, badly behaving head and neck cancers. But we could target the esophageal adenocarcinomas and the GE junction adenocarcinomas together.
Yeah. And speaking of the GE junction, Ian, you were talking about educating your gastroenterologist. I mean, certainly with this new emergence of GE junctional cancers being so prominent, what are we telling our gastroenterologists in terms of helping us classify these different tumors?
I mean, certainly, we hope that on their standard reporting of endoscopy, that they would tell us where the junction is.
Yeah.
So, endoscopically, although I do actually see some not inconsistency, but between the imaging of what radiologists call the tumor where it's at the junction versus what the gastroenterologists say that is whether the tumor is the junction, whether it extends proximally or distally. There can be some differences. But certainly I think nowadays, especially when we plan for multimodality treatment for localized disease with the surgeons and chemotherapy and radiotherapy, it is very important for our gastroenterologists to accurately document for us the location of the junction or the location of the tumor relative to the junction.
And this is the Seward classification, right? And we're seeing this more and more in clinical trials, that they actually want to know, is it the top, middle, or bottom of the GE junction that might give us a little bit of a difference.